All right. So just some disclosures there quickly before we proceed. So our objectives for the talk today, we're going to describe the physiology of normal hepatic vascular waveforms so you can really understand what underlies the morphology of those waveforms. We're going to discuss some common pathologic alterations in those waveforms, and then I'm going to hopefully give you the tools to provide a targeted differential diagnosis for when you encounter a pathologic waveform. So we'll start by going through the normal waveforms, and then we'll discuss the pathologic waveforms. We'll start with the hepatic vein, and we're going to try to classify those abnormalities into either increased retrograde pulses or decreased antegrade pulses. For the hepatic artery, we'll try to classify those as either high or low resistive index abnormalities. And for the portal vein, we'll lump those into two categories, cases in which we see decreased antegrade flow or even retrograde flow, and then cases in which we see increased pulsatility of the portal vein. Okay, so starting with the hepatic vein waveform. So the normal hepatic vein waveform has either 3 or 4 separate waves. The A wave is this little bit here above the baseline, which is flow toward the transducer, retrograde flow. The S wave and the D wave, which are the dominant waves below the baseline, that's antegrade flow. Usually the S wave is going to be deeper than the D wave. And then the V wave, which sometimes manifests as a little bump here above the baseline of retrograde flow, but probably more commonly is just this sort of trough between the S and the D waves. So let's understand why we see those waves, and to do so, I've created this diagram kind of showing what it looks like when we're interrogating the hepatic veins, usually with a transducer that's anterior to the liver. And as you've noticed here, I've taken some liberties with the anatomy of the IVC here, but just wanted to show you the connection to the heart there. Okay, so the first thing to know is that this collection of waves, A and V, S and D, that constitutes one cardiac cycle. So what's going on in terms of the cardiac physiology? So again, just as a reminder, this is retrograde flow here above the baseline. That's blood flowing toward the transducer. And this is antegrade flow that's away from the transducer, which is toward the heart. And this is sort of the opposite of the pattern that we see typically when we interrogate the portal vein and hepatic artery and the hepatic hilum. Okay, so A is for atrial contraction. So the first part of the cardiac cycle, the right atrium contracts, it pushes blood into the right ventricle. But because there are no valves separating the right atrium from the hepatic veins, you get this sort of momentary period of retrograde flow through the IVC into the hepatic veins, giving that little pulse above the baseline. Then S is for ventricular systole. So what happens is as the right ventricle contracts, the tricuspid valve is closed. You get the free and septal walls of the right ventricle coming together, but you also have this apical excursion of the closed tricuspid valve plane. And what that does is it creates some negative pressure in the right atrium, and that promotes blood flow out of the hepatic veins into the right atrium. So that gives rise to this sort of large antegrade pulse here. V is when the valve pushes back. That's the mnemonic that I use. So as the right ventricle starts to relax during diastole, but the tricuspid valve is still closed, you're going to have this sort of closed valve plane putting pressure back on the right atrium, which is either going to slow flow down or it's going to cause a temporary reversal of flow. Either one is normal as long as the V wave is very small above the baseline. And then finally, during diastole, the tricuspid valve will open up, and that just sort of creates this potential space. The right atrium can empty passively, and then that can augment the antegrade flow within the hepatic veins. Okay, moving on to the hepatic artery waveform. So what's normal? So normally we expect to see a brisk upstroke during systole with a short acceleration time. Acceleration time is the amount of time between the start of the upstroke and the peak of the upstroke. That should be less than 80 milliseconds. And then we'll also look at the end diastolic velocity, which is right here, and the peak systolic velocity. And we can calculate a resistive index using this equation. So the peak systolic velocity minus the end diastolic divided by peak, and normally in the liver that's going to be in the 0.5 to 0.7 range. All right, portal vein waveform I think is a bit more complicated, but what we should normally see is antegrade flow within the portal vein, and the velocity should be between 15 and 40 centimeters per second. And there's this concept of a pulsatility index, which I think is kind of confusing. It's calculated as the minimum velocity divided by the maximum velocity. It essentially results in this inverse index in which pulsatility index closer to 1, higher numbers actually indicates less pulsatility than a low pulsatility index. So the way I just sort of remember it is it's normal for this kind of trough to be 50% or greater of the peak. When it sort of drops below that, or if you have any retrograde flow, that's abnormal. So to understand what's going on in terms of the pulsatility in the portal veins, we have to think about how the portal veins are connected to the hepatic veins. So this is sort of a schematic of the microanatomy of the liver lobule. So we have portal veins and hepatic arteries providing flow to the sinusoids, which are essentially the capillaries of the liver. And then the sinusoids will drain into that sort of central vein in the hepatic lobule, and then those are connected back to the hepatic veins. So we see these, in a lot of patients, these sort of periodic augmentations in the portal vein flow. And the reason that's happening is because this is the period in time when there's antegrade flow within the hepatic vein. So as the hepatic veins have antegrade flow, the sinusoids are clearing out. That sort of makes it easier for the portal vein to fill the sinusoid, so there's that augmentation of flow. Similarly, when we have that period of retrograde flow within the hepatic veins during atrial contraction, that leads to relative stasis within the sinusoids, which means that the portal vein inflow has to decrease as well. So that sort of shows you how what's happening with portal vein pulsatility can be a manifestation of what's going on in the hepatic veins. Okay, so let's go into some cases here. So first case, 51-year-old woman, elevated transaminases, came to the ED and got this liver Doppler examination. The first thing that we'll note here in this portal vein waveform is that there's this increased pulsatility. So we can see that the trough here is way below 50% of the peak, and we actually have these periods of retrograde flow. So usually, when we see this waveform, we suspect that the answer is probably going to be in the hepatic veins. So when we look at the hepatic veins, we see this kind of to and fro or sawtooth pattern of these large pulses of retrograde flow, the A wave and V wave, and then the S wave and D wave. You can imagine if you sort of integrated the area under those curves that you would have sort of just barely more antegrade flow than we have retrograde flow. So it's telling us there's relative stasis within the liver. So this patient went on to have an echo, and there was marked left ventricular enlargement. The LVEF was only 10%, so this patient had right-sided heart failure secondary to left-sided heart failure, and just a little bit of mild tricuspid regurgitation. Okay, so in this case, we had a congestive hepatopathy due to the severe systolic heart failure, and that was giving rise to increased hepatic vein pulsatility. So why do we see these changes in the waveform? So if the RA is volume overloaded, there's going to be a large volume of retrograde flow during atrial contraction, which means that there's going to be a larger pulse above the baseline representing that A wave. Similarly, when the RA is volume overloaded, we're going to have a large volume of retrograde flow during atrial excursion of that closed tricuspid valve before that tricuspid valve opens, so that that's going to give us this large V wave. Now, if you're ever sort of in doubt as to is this one cardiac cycle from here to here, or is this one cardiac cycle from here to here, just know that you always have timestamps going along with these waves, right? So, if this were one cardiac cycle, consisting of 4 peaks, that's about 1 second here on this timestamp. So that would indicate that the patient's heart rate's around 60 beats per minute. In contrast, if we had sort of a 2-peak cycle, 1, 2, 1, 2, that would indicate the patient's heart rate's more like 120. So if you have knowledge of the patient's heart rate, if you have a hepatic arterial waveform, that can kind of help you sort out how many waves constitute one cardiac cycle, which can be helpful in sort of sorting out which wave is which, and then in identifying associated pathologies. Okay, here's another case. This was a case that I read, I think, early in my career as an attending. The patient who came to the ED with hyperbilirubinemia, right upper quadrant pain, had not been to a doctor in decades. So we did this ultrasound as a first step, and the bile ducts looked fine. There was no evidence of biliary obstruction. The answer in this patient was actually in the liver Doppler. So what we see here, just morphologically speaking, that the IVC and the hepatic veins are markedly dilated. We look at the portal vein, we have that same kind of pattern of to and fro flow, so increased pulsatility. And then we look at our hepatic vein and we see something strange. So this patient's heart rate was around 60, so we're thinking that one cardiac cycle is probably from here to here, and then it's repeating again. We have 3 waves above the baseline and only 1 wave below. So when you see that sort of pattern, what you're going to think of is tricuspid regurgitation. And this patient, this is what we suggested based on the ultrasound. The patient went on to get an echo, and the patient had heart failure and severe tricuspid regurgitation, so confirming our suspicion. All right, so this goes back to the relationship of the S and D waves. So under normal circumstances or cases with trivial tricuspid regurgitation, the S wave should be deeper than the D wave, as shown here. As the patient develops mild or moderate tricuspid regurgitation, that S wave becomes less deep. So, normally with the S wave, you have that apical excursion of that tricuspid valve plane that creates a negative pressure in the right atrium, and that'll promote filling of the right atrium from the hepatic veins. But if you have a regurgitant jet that's going from the right ventricle back into the right atrium, that's decreasing the amount of blood that can sort of pass into the right atrium from the hepatic veins. So this S wave will be more shallow than the D wave. And then as the tricuspid regurgitation becomes more severe, moderate to severe cases, that S wave can move toward the baseline. In really bad cases, it can actually go above the baseline. So in this case, we have A, S, and V all above the baseline, and our only antegrade wave is the D wave during diastole. Sometimes this S wave can even merge with the A wave and the V wave, and you can have just sort of an ASV complex. So that's one thing you might see. Okay, so going on to other things that might affect the hepatic veins. This is a 50-year-old woman, elevated transaminases, and the main portal vein waveform looked okay. Not a ton of pulsatility, but that can be normal. Hepatic artery, a nice brisk upstroke, looked pretty normal there. But this is a really abnormal main hepatic vein waveform. So we see that rather than that sort of triphasic or quadriphasic appearance that we saw, we just have like kind of continuous antegrade flow, with maybe a little bit of pulsatility in there, but not much of a difference over the cardiac cycle. So when we see that pattern, what we think is that there's something that's kind of causing a disconnect between the pressure fluctuations in the right atrium and the pressure fluctuations in the hepatic vein. So there's something that's kind of like blocking the communication and preventing those pressure waves from being transmitted back into the hepatic vein. So in this case, we looked distally, and we saw this. So sort of kind of isoechoic mass that seemed to be at the hepatic vein insertions there. And then there was no flow within the upstream right hepatic vein, so that looked like that was thrombosed. This patient went on to get an MRI. Coronal T2 weighted image here shows that large filling defect within the IVC. A big portion of that was enhancing, so this was tumor inside of the IVC, and then there's that little bit of the occluded right hepatic vein from bland thrombus. This got biopsied, and this was a leiomyosarcoma arising from the IVC causing hepatic vein stenosis. So in this case, what was happening was that the mass was sheltering these hepatic veins from those pressure fluctuations in the right atrium, and there's a differential for that. So you're just going to be thinking about some sort of downstream obstruction from stenosis, such as a caval anastomosis in a transplant patient, or obstruction by a mass or even a bland thrombus if you're interrogating the hepatic vein upstream to where the thrombus is located. There are some reports that sometimes you can see this pattern just in patients who have cirrhosis, and that's just due to decreased vein elasticity, so the surrounding liver can't accommodate those pressure fluctuations as much, and they become less pronounced. Okay, another case here, kind of moving on to arteries. So 64-year-old woman with 1 day post-orthotopic liver transplant. Pretty normal looking main portal vein, antegrade flow. Not the prettiest hepatic vein waveform, but you can kind of see the semblance of three separate waves there. But the main hepatic artery has issues here. So we have nice brisk arterial upstrokes, but really no diastolic flow to speak of. So this patient has a resistive index of 1. So in this case, this was simply due to anastomotic edema and vasospasm, which is something that pretty commonly happens around the arterial anastomosis in these liver transplant patients and leads to an elevated resistive index. So you have vasospasm or edema at the anastomosis. It's harder for the artery to push blood past that point, so greater resistance downstream. So it's never normal to have absent or reverse diastolic flow in the hepatic artery. But it can be, relatively normal to have a mildly elevated RI. So, somewhere in that, 0.7 to 0.8 range, we sometimes see that just sort of in the postprandial state when there's, greater portal vein inflow. reducing the ability of the hepatic artery to push blood into the liver, or in patients just sort of as they get older. But in the post-transplant setting, we see this pretty commonly. Usually the RIs aren't all the way up at like 1. They're usually more in kind of like the 0.8 to 0.9 range. We usually recommend a 24 to 48 hour follow-up, and that RI typically will normalize at that point. So differential for an elevated resistive index in the hepatic artery. So cirrhosis, you would think you've got this really fibrotic organ. It's going to be hard to move blood through that. And that can sometimes result in an elevated RI, but oftentimes also with cirrhosis, there'll be coexisting arteriovenous shunts that will form, and that will kind of tend to offset that increase. So oftentimes with cirrhosis, the RI is relatively normal. Hepatic congestion, so obviously if you've got a really congested liver from heart failure, tricuspid regurgitation, that will sort of increase the kind of blood volume in the liver, harder to pump blood in through the artery. Transplant rejection, you can imagine a lot of inflammation, edema within the liver. That could also make it hard for the hepatic artery to flow into the liver. And then sort of downstream stenosis. So if you're measuring in the hepatic artery proximal to the point of stenosis, then you'll see an elevated resistive index. And we'll kind of see the counterparts of that here in a moment. Okay, so this is a patient with PSC who had a cholangiocarcinoma, eventually underwent a liver transplant. So I'm showing you a lot of images here, but let me just sort of walk you through these. So looking at the main hepatic artery, the waveform looks pretty normal. RI is in the normal range. Looking at the right hepatic artery, RI is also in the normal range. But when we get to the left hepatic artery, we see that we're all the way down at 0.4. So lower limit of normal is generally 0.5. So let's keep going and see what else we find. So main portal vein velocity, there was this sort of focal aliasing right here, which we thought was probably right around the area of the anastomosis. We sort of wrote that off as likely due to anastomotic edema. But then when you get to the portal veins, that's where things really get interesting. So the right and the left portal vein. So we're kind of normal antegrade flow in the main. I didn't show you the right, but it was normal there. But in the left, we have this strange flow reversal here, right? So this normally we should be seeing flow toward the transducer here as it sort of takes off from the main portal vein. But we have reverse flow, and we have this kind of like weird arterialized pattern almost, right? You see this kind of this increased pulsatility, but it almost has these sort of brisk upstrokes, and also almost looks like an end diastolic velocity and the peak systolic velocity. And then in the hepatic veins, we saw this kind of monotonic antegrade flow. We didn't see those nice pressure fluctuations from the right atrium. So this case really has it all, and I think it was easy to figure out what was going on, from the ultrasound, but the CT I think also nicely illustrated it. So we see here that there is a really dilated hepatic artery here, and that if you follow that up into the liver, there was a branch that went all the way out to the periphery of the left lateral section here, and there was this strange vascular structure here. And you can see here, if you look at the left portal vein, that has arterial type of enhancement, right? So that looks at the same attenuation as that hepatic artery branch in the aorta, whereas the right portal vein has a different attenuation. So that explains what we saw in the ultrasound, because that left portal vein was filling retrograde and is basically enhancing like an artery. So we're seeing those arterial fluctuations in that left portal vein. And this is an abnormal connection between an artery and a vein in the liver. This patient also had a little bit of narrowing at that main portal vein, anastomotic region, and then some caval stenosis there as well, which accounted for that hepatic vein waveform. So it was really unclear what happened in this case, like if this patient, this donor liver had an AVM in it to begin with, or if there was some sort of, traumatic AVF that formed during surgery. I don't think we ever really got a firm answer on it, but, IR went in there and treated it. But in this case, that was causing increased portal vein pulsatility. So let's talk about the differential for when you see increased portal vein pulsatility. We saw some cases at the beginning, right? And there was increased pulsatility in the hepatic veins. And that's probably the most common reason you'll see increased portal vein pulsatility. That can be due to heart failure, tricuspid regurgitation. In that case, the portal vein will kind of resemble that congested hepatic vein with that sort of to and fro flow like this. And usually you'll have sort of 2 peaks above and 2 peaks below for a given cardiac cycle. So you can imagine, here to here, that amounts to a heart rate of about 60 beats per minute, because this is 1 second. In contrast with arterial shunting, where there's an abnormal communication between the hepatic artery branch and the portal vein, you can have either antegrade or retrograde flow in the portal vein, depends on where that shunt is located. The case I showed, it was really peripheral in the liver, so the flow was retrograde coming back from that point toward the hilum. We can see it with cirrhosis in some cases where there is robust arteriovenous communication, and we can see it like in this case with either hepatic AVM or an AVF. In this case, the portal vein is going to have a different sort of morphology. It's going to resemble a normal hepatic artery with like a discrete upstroke and sort of a kind of low-level diastolic flow. And there's going to be one peak per cardiac cycle as opposed to having 4 peaks, 2 above and 2 below. Okay, here's another case. 73-year-old woman with weight loss, postprandial abdominal pain. Main hepatic artery waveform. So, we see an upstroke here, but it's not very brisk. And then we have this sort of slow decline in the diastolic flow until our next upstroke again. We had a resistive index of 0.2 in this case. So when you see that, you're going to think that there's some sort of stenosis upstream that's blunting that upstroke. So let's talk about the differential for a decreased resistive index in the hepatic artery. So in this case, this was due to an upstream stenosis, just atherosclerotic disease, probably the most common thing, especially in older patients. And in this case, the RI is reduced because there's reduced systolic flow. So that normal brisk upstroke is severely blunted. And this is basically the equivalent of a parvus at tardus waveform. You'll have prolonged acceleration time. So in this case, it took about 300 milliseconds to get from the start of the upstroke to the peak of the upstroke. And then these are just sort of the common etiologies, atherosclerosis. Younger patients, you can think about things like median arcuate ligament syndrome, or if you are sort of in a sort of transplant population, if you're measuring downstream to the anastomosis, there might be some upstream edema or fibrosis if it's more of a chronic issue. Or in sort of the immediate post-op setting, an upstream thrombosis that may be causing some stenosis of the vessel. But you're concerned about an issue proximal to the point where you're interrogating the vessel. Now contrast that with what we see here in the case of downstream shunting. So in this case, the RI is decreased due to augmented diastolic flow. So we still have our nice brisk arterial upstroke. But what we see is that rather than the diastolic flow dropping off to somewhere perhaps around here, it stays pretty elevated throughout the entire cardiac cycle. So our systolic flow is preserved. We have a normal acceleration time, but we have a lot more diastolic flow than we otherwise would have. So very different morphologies here. They're both manifesting as low resistive indices. And in this case, you're going to think of some abnormal communication between an artery and a vein. As I said, in cirrhosis, sometimes you get a lot of arteriovenous shunting as those collaterals form. But you're going to be thinking about things like HHT with hepatic AVMs or hepatic arteriovenous fistula, which oftentimes is either going to be traumatic or iatrogenic. Okay, going on to another case here. So it's a patient with abdominal distension, where when we look at the main portal vein, we see an issue, and here we see the blood flow is hepatofugal or away from the liver rather than hepatopedal or into the liver. We look at the right and the left branch portal veins, and they're both reversed as well. In terms of the reason for this, we look at the liver, we see ascites, and we see some surface nodularity. So this is a patient with cirrhosis and portal hypertension, giving rise to that retrograde flow in the portal vein. So in this case, hepatic fibrosis increases the resistance to portal venous inflow. That's sort of perisinusoidal fibrosis. And that initially decreases the main portal vein velocity. So it'll remain antegrade, but it'll drop below 15 centimeters per second. Eventually, it'll kind of get to the state where there's like relative stasis in the hepatic vein, where it's hard to detect flow, and that's when you're sort of at risk for developing portal venous thrombosis. And then, with that sort of prolonged elevation of the portal venous pressures, you'll develop low resistance portosystemic collaterals, and that's when the flow reverses and sort of goes toward the path of least resistance. Kind of a variant on that case here. So another patient who has known cirrhosis, and we see kind of a different pattern of flow within the portal vein. So we have antegrade flow in the main portal vein. We have antegrade flow in the left portal vein, but we have retrograde flow in the right portal vein. So So why is this happening? Well, sometimes, there can be spatial heterogeneity in the degree of fibrosis within a liver, but this patient had clear evidence of cirrhosis, and it was pretty advanced. So the answer really comes when we sort of look for those collaterals. As I said, everything's going to go toward the path of least resistance. This patient had this really large recanalized umbilical vein, and really all the portal venous flow was headed toward that vein. So the portal venous flow in from the bowel was coming through the main and going into the left, and then on the right side, the flow going into the right hemiliver from the hepatic artery, crossing through the sinusoids, was just coming out backwards through the right portal vein, crossing over into the left portal vein and flowing out of the liver in that fashion. Okay. All right, so to review, for our hepatic artery, normally we expect to see a resistive index in the 0.5 to 0.7 range, and we should have an acceleration time less than 80 milliseconds. When we see an elevated resistive index in the hepatic artery, that can be normal, like in the postprandial state, but it can indicate that there's some sort of intrinsic liver disease, that the liver is perhaps congested due to something like CHF or tricuspid regurgitation, or that you're measuring at a point in the hepatic artery where there's like a downstream stenosis that could be atherosclerotic, it could be vasospasm, edema from an anastomosis. In contrast, we see a low RI in the hepatic artery. That's going to suggest one of two things. One thing is that there could be upstream stenosis. So there's some sort of stenosis that is more proximal in the vessel, and that's leading to sort of blunting of the systolic flow at the point where you're measuring. Alternatively, you can have downstream shunting that results in augmented diastolic flow, where you have that preserved systolic peak, but just more flow after that peak throughout the cardiac cycle. And that's going to make us think of things like AVF, AVM, for example. Okay, hepatic veins. So normally it's a triphasic or quadriphasic waveform, depending on whether that V wave is above or below the baseline. The normal appearance is an S wave that's deeper than the D wave, and you should have small A and V waves. So we split our differential into what we see with increased retrograde pulses or decreased antegrade pulses. So increased retrograde pulses means that the A wave and the V wave are bigger than they should be, or you potentially have an S wave that's flipped up above the baseline. So it's going to make you think of right-sided heart failure due to whatever cause, or moderate to severe tricuspid regurgitation. Sometimes these things coexist. Patients get really dilated right ventricles, and then the tricuspid valve leaflets won't coapt properly. In contrast, if we see those decreased antegrade pulses, so the S and the D waves become blunted, or you basically just see continuous antegrade flow, you're going to think that there's something downstream that's obstructing the vessel and kind of sheltering or sequestering the hepatic veins from what's going on in the right atrium. So think about downstream thrombosis, Budd-Chiari syndrome, IVC thrombus, or some sort of neoplasm that's growing into the IVC. Sometimes you can see this just with decreased hepatic elasticity with cirrhosis. And then finally, the portal vein. So you should normally see antegrade flow, velocity of 15 to 40 centimeters per second. And then the trough, or the lowest velocity, should generally be 50% or higher of the peak. When it drops below that or changes direction, that's an indication of increased pulsatility. So when we see low antegrade flow or reverse flow, we're thinking that this patient has portal hypertension, and there's some sort of extrahepatic portosystemic collateral where the blood is being shunted, though, as we saw in that one case, sometimes the collateral is inside the liver or rising from inside the liver, in which case the rules are violated. And then cases of increased portal vein pulsatility, most commonly that's going to be due to increased hepatic vein pulsatility, so you have that same kind of to and fro flow like in CHF. And then pretty rarely you can see an abnormal connection between an artery and a portal vein branch, like an AVM in an HHT patient or an AV fistula following trauma or surgery. All right, so I hope that helps you all read these exams in the future and sort of go beyond simply saying the vessel is patent, because there's a lot of information buried in the morphology of that waveform, and it can sort of lead you to a more specific diagnosis. Thank you.